Good evening, everyone. Good evening. This is Patience. I'm back. The last time I discussed with you was safety and effective care environment. Safety and effective care environment. I spoke about delegation and assignment. I spoke about the role of the registered nurse, the role of the licensed practical nurse, that's the LPN, and the role of the unlicensed assistive personnel, that's the nursing assistants on the floor. And I discussed about assignments you could delegate and what you should not delegate, and the principles for delegation and how to be an effective delegator. So today I'm continuing on that topic. It's still under safety and effective care environment. Is under management of care when you look at your the test plan. This is under management of care, and management of care does have a bigger percentage of your NCLEX exam. So today I'm talking about critical thinking. Critical thinking. After we have discussed the video on the role of the LPN, RN, and the unlicensed assistive personnel. What is critical thinking? So it involves creativity, problem solving, and decision making. So your ability to solve problems, your ability to make a decision, and your ability to be creative in solving that problem. So your ability to tackle issues that come your way. So critical thinking is what you need to pass the NCLEX as well. So the nursing responsibilities in critical thinking is to observe. You are to be a good observant. So this also leads you to thinking about how to deal with the NCLEX and the NCLEX questions. You have to be a good observer. Decide what data are important. So some data you get in the NCLEX questions are not important to the question. It's not going to help you get the answer, but you need to be able to understand which of these data is more directive as to what is requested of me in the question. So that's critical thinking. You need that for the NCLEX as well. So validate and organize data. So as a nurse, your job is to be able to validate and organize data, to look for patterns and relationships. So you look for patterns in patient situations and the relationship from the initial to the current level. Then you state a problem. You state a problem. That is when you're using the nursing process, you go through critical thinking as well. You'll be able to get a problem and then you state what the problem is. Then you apply your nursing knowledge. So your nursing knowledge is what you're actually learning from the books to understand. So you have to make good use of that. So that's why NCLEX is pushing you hard to be able to learn and understand what you are doing. Evaluate according to criteria that is established. So you evaluate every patient according to the criteria that is established. So if they tell you to monitor vital signs every 15 minutes because of the patient's situation, Q15, you have to go back and monitor the patient's vital signs. So you evaluate the patient accordingly. Now let's talk about decision making. Decision making. What is decision making? We just spoke about critical thinking. Decision making is purposeful and goal directed. The nurse identifies and selects options and alternatives. So to make a decision, you have to select and make and choose alternatives. You just don't decide on everything. Output, your output is as well is part of your decision making ability. What you are going to decide, you should be able to come up with an output from that decision. Now, what are the types of decision making? We have the prescriptive decision making. This one involves routine decisions with objective information. Objective information is what you gather. So objectively, you are able to gather information about a certain scenario. That's decision making. That's a prescriptive one. Options are known and predictable. So in that case, you know the option and you can predict it. Decisions made according to standard procedures or analytical tools. So the doctors have a list of books or a list of guide that they use. So if a patient come in and you think this is myocardial infarction, this is the descriptive directive you use to make a decision from. So it's prescribed already. It has been given. The directive has been stated. The criteria, the medication to follow to treat abdominal pain has been stated down. So all you just need is to go to the criteria that has been established to choose them. So you have options of those medications. So if you cannot use ibuprofen, you can use naproxen to manage pain. So this has been prescribed. So you already have a background knowledge of the outcome. You can predict it as the one making that decision. Behavioral decision making. This one involves the non-routine and instructive information. Non-routine is not routine and it's instructive. Options are known or unpredictable. You may know the option or you may not be able to predict it. Decision made by obtaining more data, using past experience, using creative approach. That's the decisions that you make using your past experience. So for those who have worked and they have experience, they're able to use that to identify some other decisions. And as a nurse, you will always be in that shoe. All you need is to come out of yourself, learn, and be able to be proactive in your decisions. So you have to be proactive first before you can make good decisions. Optimizing. The goal for optimizing is to select ideal solution. The best decision comes from this process, but the most time consuming. The optimizing one is most time consuming. It does consume a lot of time to use that in decision making. So we have the phases of decision making. You have to define an objectives. You have to generate the options. You have to analyze all the options you are using to make that decision. You have to identify advantages and disadvantages. You rank the options that you have made and the advantages and the disadvantages. You weigh them to see which one takes the priority. Select options that will successfully meet the defined objective. So this is what you also use when you are choosing NCLEX question. You select answers that will successfully meet what is actually required. Implement the selected option and you evaluate the outcome. Now let's go to problem solving. The focus is trying to solve immediate problem, and this one you are trying to solve a problem. And trying to solve a problem, it involves making a decision. So that's part of it. So the methods, you use several methods. We have the trial and error method. So this one, repeated attempts at different solutions until it is identified that one solution works best. This is what they basically use for clinical trial in most options. They use try and error because you don't know what the outcome will be. You cannot predict the outcome in this decision making. So you are just trying to see what will work out best. So this is used by inexperienced staff. So if you are the nurse and you just graduated from nursing school and you go and then you give the medication, or you go and you are poking the patient, you are doing try and error, especially those who try to learn how to insert the IV lines. Mostly they do try and error. I've seen several of them. So try and error, they're trying and they're making mistakes, but they learn along the way. We have the experimentation, the study problem using trial periods or pilot projects to determine best outcome. So this is what most research companies does use, say pharmaceuticals. In most cases, will use this step. They'll use the experimentation. They will study the problem using a trial period or pilot project to determine best outcome. So they will also have a greater, this method of problem solving also have a greater probability of achieving best outcome if sufficient time devoted to the process. So this is what we just went through with the COVID vaccine trial, clinical trial, and all those things. So it does take time to have this one done because it has to go through a period of trial and a pilot study project process to be able to achieve a goal. But in the end, they get a good result most often. Purposeful inaction, do nothing approach. Listen, On the NCLEX, never choose an option that is a do nothing approach. That means you're just letting it go. You can't help it. So use when problem is judged to be significant or outside a person's control. So you can only use the do nothing approach in the NCLEX when the question presents to you and tells you the nurse has done all of this, the nurse has done what is supposed to be done within her qualification limit, within her standard of practice, within the nurse's code of conduct, and there is nothing to do than to just call the provider. So be mindful. We have do nothing answers on the NCLEX. Don't choose them. Now the steps to this to problem solving is to define the problem. You gather your data, you analyze the data, develop solutions, select and implement a solution. So you develop the solutions and you select which of these solutions do I want to get. Let me implement that one. Then you evaluate your result after you have gotten that. Distribution of resources. This is another component of management of care under safety and effective care environments. Distribution of resources. So gives an individual what he or she deserves regardless of race, color, creed, gender, or socioeconomic status. Provides equal access to care for all patients. So this is the basic principle that America goes with because it's a multicultural country. So it does provide, when you are taking care of the NCLEX patient, it doesn't matter the color, the care, it doesn't matter the color, the ethnic background, you provide all of them equal as deserved. So unless they start asking about ethical questions that has to do with the person's ethical background that can affect the person's outcome or the person's diagnosis, that's a different stuff altogether, which I will discuss later. Resources, the resources that mostly is distributed is the staff nurses. So on the NCLEX, this is where delegation and prioritization fall. You become a resource to be moved to another unit when your services are needed. If you're a special nurse in the NICU and they need you in the I would say the labor and delivery unit. So you are in the NICU and they need you in labor and delivery. When you get there, they will probably look at the fact that you are from NICU, neonatal intensive care unit. Neonatal intensive care unit. Then they say, okay, so since you are from neonatal intensive care unit, it will be best for you to take care of the baby when the woman delivers. That's resources. So you become a resource there. The time, the equipment, supplies, and your knowledge. So take note of that. Allocation of resources. So you make a decision regarding how resources will be distributed. There's a finite number of resources in healthcare that must be used wisely and efficiently. So I wonder if NCLEX is actually going into details with this, but you just need to know it as well. Okay. So the primary principle is to provide the greatest good for the greatest number of people. So if you have a lot of things to distribute in nursing, like you have some patients that are in need of bedpan, those are all part of resources that you distribute. Now let's talk about the nursing management of aspect of this. We have the judiciously used resources to achieve identified client goals. So nursing use resources for clients as well. So they use it wisely though. Nursing coordinates the services regarding the services received by a group of clients over a specific period of time. So nurses does the coordination. Like I told you, it's an interdisciplinary team and everybody step into help. Standards of care and practice guide nursing activities. So nurses also use standard of care, which guide nursing activities and use to evaluate the quality of care. Resolution of conflict. As nurses, you'll be faced with a lot of conflict. As NCLEX students, you are studying for the NCLEX, a lot of conflicts you will face before you pass the exam is conflict resolution. You have to know how to resolve those conflicts. So you determine the facts, you identify the problem with the conflict, you ask for suggestions for solutions from those who are involved. So you also define the solution. So in the NCLEX, you have a lot. So the NCLEX presents to you with a problem. So all that the question presents to you is a problem for you to solve. A patient that does not need anything will never be presented to you on the NCLEX. So if I am not sick, why do I go to the hospital? So this is where you need to know how to group patients, how to identify, how to solve problems, how to make decisions, how to critically look into things, and how to come up with solutions. So now let's talk about documentation. So on the NCLEX, you are expected to know how to document as well. As nurses, you will be faced with questions that talk about documentation, because everything you do, every step you take, it comes down to documentation. If it is not documented, it wasn't done. So the purpose of documentation is to promote communication. Even as you give report to the other nurses, and on the NCLEX, they can ask you about reports, endorsement and reports questions as well. We'll get there. Excuse me. So we have the purpose of documentation is to promote communication. So if I work here today and tomorrow I'm not here, another nurse come, you should be able to know what went on yesterday. That's why nursing is a 24-hour job. It doesn't matter who you are. You can be a PCA, you can be an unlicensed personnel, you can be a registered nurse, you can be a doctor, you can be a social worker. Everybody documents in the patient chat, and that promotes communication. It promotes continuity of care as well. And it is also a legal record. Patient document is a legal record, and this meets requirement for regulatory agencies. So those who make the laws, is also their requirement. So if Joint Commission or the state is the one that certify the facility, they require to see patient documentation. They give you a standard of what they want. Required for also third-party reimbursement. So documentation is also needed for reimbursement purposes. So insurance companies want to know what you actually did. It has to be documented. You cannot just send me a phone call and say, oh, hey, I saw this patient, I ordered CT scan, they're going to charge the patient for CT scan without seeing any documentation that CT scan was ordered. So that's where it starts from. And there has to be a result for the CT scan. So everything you do in nursing, remember documentation. So when you are faced with questions about documentation, the purpose of documentation is to promote communication. It meets regulatory body or regulatory agencies requirement, like those that certify the facilities, Joint Commission for hospitals, and the state requirement for hospitals or nursing homes. So those are the regulatory bodies. They make the laws for them. And it also meets the requirement for reimbursement. Third party insurance companies, they also make their reimbursement based on that. So that's the purpose of documentation. You need to have that on your fingertips. Characteristics of good documentation: it has to be legible. You have to be able to see. Don't go and write and then I come and I cannot read, then it doesn't make sense. So it has to be legible, has to be actual, factual, no summarizing data. Don't do a shortcut. Don't just go and put what's the name, you use jargons and put it in the patient chat and get up and go home, because I'm not going to understand. It has to be simple, actual, factual. It has to carry the real fact, timely. So if you did a procedure at 6 a.m. and you are not documenting it at 7 p.m., it doesn't actually reflect the time. So mind you that one too. Well organized and concise. It has to be confidential, proper grammar and spelling, authorized abbreviations. So you can only use medical abbreviations like chronic kidney disease. You can use CKD, but don't go and use too many abbreviations in your note that nobody will understand what it is. Okay, don't go and use too many abbreviations that nobody will understand what it is. It wouldn't make sense in that chat. So documenting changes in client condition is also part of your job. So you assess the client's vital signs, symptoms, behaviors, complaints, responses to treatment when needed, or PRN medications and dietary changes, input and output, all that get documented in patient chat. Interdisciplinary team information. So if the patient had a care plan meeting, if the patient had a social worker meet them, if the patient had the account care manager, if the patient had the case manager meeting, they all get documented in the patient chat. Those are all conditions that has to be documented. Notify physician if client physiological status and functional ability changes significantly. All that you document. So you notify the physician if there's any change in patient situation. You reported it, you document. You have to always follow the documentation till you have intervened and what was the outcome of your intervention. Then it has to all come up in your documentation. So you notify interdisciplinary team of changes in patient medical complaint, medical problem, medical issue. It got documented as well. Notify family members or other significant others of the patient. Everything gets documented in the patient chat. You don't want to leave that out. Now, the nature of the changes, you have to tell them why changes were made, actions that were taken to provide need care for the client when you are documenting. So this is just teaching you what to talk about in your documentation. List of revisions on medical plan of care. So if there's a revision in the patient plan of care, you document. Follow policies for privacy and confidentiality. So take note of all of that. Document in timely manner, date and time, nursing assessment, name of the physician that was informed about a problem, the time and the method that you use to contact the physician. And then you go in and talk about the information provided about the client. What did you tell the doctor about the patient? Was it through an email, which is usually not advisable? Phone call, which you can do. You can call a doctor on the phone and you tell the doctor. So inter-facility, you have the doctor's extension, you use the doctor's extension and you call. In an emergency, you call and then you explain, I have a patient so and so, condition change to this and that and that. That's what you do about documentation. So you inform who you had given the information to. You also call the family member, and then you also document. So everybody you speak to, you get their name and you record. It's part of good documentation. The responses by the client and the member of the family or any significant other and what they responded to you. So you walk in and you had the patient, and until like 5 a.m. the patient started having symptoms. Patient's condition changed. Patient ended up being intubated, and after intubation, patient didn't make it, patient died. Then you have to call the doctor and you start. The patient, by then the doctor would have been aware, because the moment the patient condition starts changing, you have to call the doctor and you let the doctor, hey, this is what happened, this is what happened, and the patient went into cardiac arrest, the patient is this and this, can you come in, any orders? The doctor will be around on the floor, and then the doctor will also add up whatever they have. But when the whole scenario finished, you have to call the family, you have to explain to them what is going on. But mind you, nurses don't give result for death. You don't tell family your family member died. The doctors will call to always notify them. That comes with facility policies and standards, but nurses, as the code of conduct or as our code standard of practice, you are not the one to report death. Okay, so if the patient condition change, you can call the family and tell them patient condition change. She was doing worse in the morning, right now patient is doing fine. And mind you, who you always call, the patient has a significant other, the information you have on the phone, the patient has information, so you contact the right phone number. Don't just call any family member you want, because the patient might not want you to give the information out. The healthcare proxy is what you think about. Okay, the incident report. Now let's talk about incident report. Definition, what is it? It's an agency record of unusual occurrence or accident and physical responses. So it's a record that reports unusual occurrences or accidents and physical responses. What was the response? It has to be accurate. It's an accurate and comprehensive report on any unexpected or unplanned occurrence that affects or cloud or could have potentially, let me take this over. So incident report the second definition I have for it is that it's an accurate and comprehensive report on any unexpected or unexplained or unplanned occurrence that affects or could potentially affect a client, family member, or staff member. So I have two definitions for incident report. The first one is that it's an agency report of unusual occurrence or accident and physical responses. The second one, accurate and comprehensive report on any unusual or unexpected occurrence that affect or could potentially affect a client, family member, or a staff member. The purpose of an incident report is documentation and follow-up for all accidents or all incidents. The purpose is to be able to follow up on that. The purpose is also used to analyze the severity, frequency, and the cause of the occurrence. Is used to analyze the severity and the cause of occurrence. It's also used in analysis and is the basis for intervention. So when they analyze it, they now have a reason, they have a baseline information to analyze the data, and then they know what intervention is required. So for instance, you have a patient that walk out with an IV line. You know the patient is at risk because the patient can get infection from having that line. That's elopement. So you have to make an incident. So the next step you have to do is to follow up and let the police know to go and look for the patient so that the patient don't go use it for drugs or the patient arm doesn't get infected. It's a big deal. So chatting, what is chatting? Chatting is documentation. So you don't, when you are documenting in the documenting about an incident, you don't include a reference to the incident report. So when you are making your nurse's note, don't say incident report was done. No, you don't want to include that in your documentation. It has to be accurate and precise. Don't use words such as error or inappropriate. Don't include inflammatory words or judgmental statements. Don't be a judge in your nursing note, in your chatting. If there are adverse reactions to incidents, chat follow-up note updating client status. Documentation of client reactions should be included as status change and should be continued until client returns to original status. So when you're documenting the reaction of a client, it should be included as a status change and should be continued until the client returns to normal. Now, the sequence of documentation is that a person discovers and reports actual or potential risk. There's a risk manager receives report within 24 hours. So when you get an incident, you put up a sequence of how it works. So this is the sequence that an incident report will work. The person that will discover and report the actual potential risk, you are the one making it up. And then the risk manager receives the report within 24 hours. So when you do an incident, the risk manager is supposed to get it within 24 hours. An investigation of the incident is conducted. So they start doing an investigation as to why this happened. Referring physician and risk management committee consult together. So the risk management has a committee, they get consulted. That's part of the interdisciplinary team measures. Now, the risk managers will clarify misinformation for clients and family. They explain what happened to client and the family. Client is referred to appropriate resources if necessary. Client is provided free of charge. The care of the client is provided free of charge if they identify the cause and they realize that this is what needs to be rectified and resolved. So all record incident report follow-up actions taken are filled in a central location. It goes to one aspect, one area of the patient record. It doesn't go into the general chart of the patient. Now we have common situations that require an incident report. So mind you on this, on the NCLEX, it's not everything that requires incident report. So these are things you need for incident report. NCLEX will ask you and you need to have it on your fingertips to go through it. So we have medication errors. So omitted medication, wrong wrong dosages, wrong route. So the doctor ordered a PO, you want to give it as IV. That's an incident report. You have to make an incident report. It's an accident. It's an incident as well. So medication error is number one reason why you need an incident report. The second one is complications from diagnostic or treatment procedures. Blood samples take, biopsy, x-ray, invasive procedures, bronchoscopy, and thoracentesis. So complications from diagnostic or treatment procedures. So the patient is getting any of these procedures, blood sample, needle stick, and the needle stick you, either you the nurse, or it doesn't stick the patient the right way, is an incident. Incorrect sequence account in surgery. So if the patient wanted to have her fallopian tubes cut and they accidentally remove the womb, that's an incident. That's an incident. Or the patient went into C-section to do C-section and have a baby come out, they end up cutting up the fallopian tubes, or they end up tying up the fallopian tubes. That's an incident report that needs to be done. That's incorrect surgery. Or the patient is supposed to go for eye surgery, they end up doing heart surgery. Serious problem. Failure to report change in patient's condition. If you fail to report changes in patient condition, it becomes an incident report. Falls, and then patient is burned. So patient come to you, the hospital end up getting burned, incident report. Break in aseptic techniques. So you don't follow the aseptic technique, patient get infection, demands an incident report. Medical legal incident. Client or family refuses treatment as ordered and refuses to sign consent. Client or family voices dissatisfaction with care and situations cannot be or has not been resolved. So you have a patient or family that come in and they are complaining and fighting and being verbally abusive. A family member, it's an incident report. Something is not working right with them. A family member that is creating trouble, making up problems, refusing to come for care plan meetings, you have to do an incident report on that. Now let's talk about change of shift report. You need to know this one as well. Regularly scheduled structured exchange of information. So regularly nurses have to change information. So change of shift report, this is pretty straightforward, and it focuses about the needs for the patient for every 24 hours. That's what makes nursing 24 hours job. And I'll tell you, even the doctors have a 24 hours job if it's in a facility setting based on the protocol. So this enable healthcare workers to organize their work for specified time period, communicate consent. So when you come in the morning, you have to take report, you have to know who to group. That's where your assignments start from. So that's where you'll be able to group which patient to see first, who to see next, who to see third. And this will include the client status when they are giving you report. So the previous shift tells you what is the client's current status right now. Is a patient stable, patient not stable? Client care of plan. Is there any current plan of care? Has there been any change since I left yesterday and I'm back today? Responses to current care. Is there any changes in the response? Is the patient responding to treatment? Patient is not responding to treatment. Is there any changes in the plan? Things needing further attention. Is there anything to follow up? Does the patient need to go for CT that the patient couldn't go on your shift? So every shift has to give report. Now reporting nurse describes the actual or potential client needs. So if you are the one giving the report, you are the one going home. You give the actual and the potential need for the client right now. How these needs were addressed during previous shift by nursing and interdisciplinary team. So if the patient had to go to OR and I came in, the patient has an order to go to OR, then you have to tell me, so what happened? I see an order for OR patient. Did the patient go? Is patient going, not going? What's the decision? So you, the one leaving who had a patient before, you should be able to tell me, oh, we are waiting for consent. We are waiting for that and that and that. This is the reason. So information about laboratory results or laboratory studies, diagnostic tests, treatment, and nursing activities that is anticipated during next shift. So you let me know. So the patient is just waiting for type and screen to be able to get blood transfusion, and the patient is waiting for this and that and that, and that's where I group my care and then I start from. So reporting nurses must legally communicate all facts relevant to continuity of care for assigned clients or assigned patients. So you are legally obligated to communicate the care to me if I am the one taking over from you. So information must be pertinent, current, and concrete. So don't go talking about what happened yesterday. Change of shift report should not contain information already known by the oncoming shift, description of routines AM or PM, rumors or gossip. You know we have rumors or gossip everywhere. Opinions or value judgment about client's lifestyle, client information that does not relate to health condition, needs, or treatment. So you have the patient that is having a problem with the husband, and the patient is not here for violence. I don't need to know that. If the patient is here for stomach pain, let's talk about stomach pain, okay? So desist from rumors or information that doesn't count. So beware of those things on the NCLEX as well. So to give a shift change report, you gather data to be discussed. You look at the flow sheet, the worksheets, the progress notes, the chart, and the patient medication. You avoid copying data in order to prevent errors and reduce the required time required. So you avoid copying it from yesterday to today. You use outline or to organize report. Use an outline. You can just write it down on a paper. So this is how I want my report to look like, and you write it down. It is okay. And to deliver a change report, you should have the client name, room number, the bed number, and the note if of the unit. If the patient is off for a diagnostic procedure, you have to add that. Medical plan. So if the patient is not on your shift right now, if the patient is not on the floor right now, doesn't mean you should jump. You still need to let the other people know there's a patient who is supposed to be in this room. This is the name, this is the date of birth, this is the room number, the bed number. The patient is here. The patient went for GYN exam. Patient went for CAT scan. You have to let the next shift know. Don't just walk out because patient is not on the floor. Okay, now we have the medical plan in reporting. You have to give the admitting diagnosis. If there's an impending admission, you have to name the attending physician, who is the doctor attending to this patient. Now the IV solutions, the flow rates, if the patient is getting any, the kind of medications that were ordered, what you have given, and what is needed to be given now. The response to treatment, expected and unexpected outcomes. You have to explain all of that. Client emotional response to the condition, the use of and the response to the PRN medication. So if patients taking morphine every 4 hours, just report that. Nursing plan, you personalize the nursing approach. Special equipment, supplies, or pacing of activities. Response to diet, the patient response, all that need to be captured in your note. Behavioral response to treatment and health status. So denial, frustration, the patient is anxious, the patient is aggressive, the patient is this. You have to report that in your notes. Nursing assessment, the vital signs, you have to explain it to the next shift. You have to get your most recent vital signs and let them know what you are leaving the patient with. Is the vital stable? Then you get the intake and output, the INO. You get the intake and output. You have to report that one too. How many ounces of juice did the patient take in your shift? Is the patient on fluid restriction? And if it is, how much? New consent, anything that was new for the patient over your shift. Changing client needs. Did the client change their decision? Client outcome, interdisciplinary plan. Did they plan to call the social worker to come and talk? Referrals, teaching plans, discharge plans, all that you need to be captured. Now the nurse that is receiving the report should learn. So all what I've been discussing is the nurse that is giving report. Now I'm talking about the nurse that is coming to take the report. You should learn the individual client symptoms. You have to ask them. You have to learn to know the symptoms, the discomfort, what has been done, what remains to be done, how client has responded to treatment and activities so changes can be made to meet the client needs. You have to explain, you have to have all that in your mind. And then for you to receive the shift change report, you have to determine the number of clients, the number of staff available for client care, number of staff available. This has to do with quality of care and time. And then anticipate admissions, transfers, discharges, and critical conditions. Client with specific need, blood transfusion, routine surgery, and then you complete assignment sheet for staff under your supervision. So if you are the registered nurse in this group, then you will be the one completing the assignment for this group. If you are the LPN in this group and there is no registered nurse where you work, you are the one supposed to be grouping up this assignment for the day, looking at the number of patients you have, the number of admissions, transfers, discharges, and all that. You write out the assignment on client care sheets, make a to-do list, identifying tasks to be performed during the shift, help to organize activities. So during change of shift report, determine appropriateness of client care assignment, and then you note key information about the client condition, the progress and responses to treatment. So the key conditions and how they are responding to treatment. Types of shift change report are the face-to-face one. So now I'm talking about the types of shift change report. We have different types of them. So we have the face-to-face. This one is reporting answers and questions from oncoming staff. So I'm standing here looking at you, you are looking at me, and then we are talking about it. So I can have the paper here, and then I'm telling you this is the patient and this and this. That's the face-to-face. This provides flexibility to report to a number of different oncoming staff. So if you are many of you, I can have all of you stand here, and then I'm reporting to all of you at the same time. Then it provides flexibility in pacing and sequencing of report. It's also, that's the importance of the face-to-face. The nurses listen to report only on their clients. So if you are going to have 5 clients, I will give you a report on those 5 clients, and you only listen to report for those 5 clients. You don't go listen to report for 30 clients if you are taking only 5 for the day, or if you are assigned only 5 of them. Now we have the tapped report. The tapped report, this is less time consuming because of lack of interruption. Nurse is frequently more systematic and thorough, gives nurse more sense of control over the process. Reporting nurse can perform nursing activities while next shift is listening to report. So reporting nurse returns to clarify the information, answers. So this one, you tap it, you just reading it to the person, and then when you finish, they ask questions for clarification. I actually don't prefer that, but NCLEX doesn't give you a choice. Whichever one they present to you, try to know what it is. Let's talk about the organization of change of shift report. We have the computerized also report. We also have the one that you walk from patient to patient and then you give the report. We have the computerized client care summary, or the CADEX care current summary of client need, status and goal. So the CADEX is just a place where they keep the client's medical information. So you open that and you read it out. Now, the method of service delivery and change of shift report are functional method. We have the RN of previous shift report to RN of incoming shift. So if I am RN, I'm taking over RN responsibility. If you are LPN, you are taking over LPN responsibility. So other staff may attend report to be given according to assignments from RN. So I just said it. So if you are PCA, you go to PCA for report. If I'm RN, but we can all go together, but you know who you are actually getting report from. Team nursing method. All members of oncoming shift attend the report. So this is actually what I do at my current job. We have the team nursing report. We all come together and then we are walking from patient to patient, and we have each person tell us about their patients. But this is done in the emergency. It may not be done in the inpatient floor because we all not taking all the patients. Okay. Now we have the primary nursing method. So after the team nursing method, we have the primary nursing. The RN assigned to direct care of individual client report to assign to the direct So this is what I just explained. So if you are taking 5 patients, you go for only 5. That's the primary nursing method. We have the case management method. Schedule structured decisions with nursing team or interdisciplinary team in addition to change of shift report. So you tell them to schedule it. When they are giving shift change report, the case manager will come and then be part of the report. So that's the case management method. We have the cultural norms. Now let's move to another topic, that is cultural norms. I'm trying to finish this aspect and then we can move on to the next time. Cultural norms. Cultural norms is a group of individuals' values and beliefs that strongly influence individuals' actions and behavior. So the cultural norms is a group of individuals. When we talk of cultural norms, it's a group of people with common beliefs, values, and they have a strong influence on their actions and their behavior. Now, the values, a value is a personal preference, commitment, motivation, patterns of using resources, objects, people, or events that have special meaning, including choices, behavior, and action. So, example is my cultural norm is where I come from. So where you come from determines your cultural norm, what you believe in, and what strongly influence that belief. So your values and everything. So if I decided to join a particular group of people and I decided to become part of them and I believe in their practices, that is what defines my cultural norm. Belief. Now, basic assumptions. Belief is a basic assumption or personal conviction that the individual thinks are factual or takes for granted. So what I believe in is what I believe in. I think this is it and that is it. So somebody tell you I have pain, but I'm managing this pain with home medication and I'm not taking any morphine. That is their belief. You can't change it. So it's used to determine the values of a person. It determines what you value. So I value this home treatment and that's it. You can't change it. It's my norm. It's handed down from generation to generation. So most of this will factor into cultural practices. It's handed down from generation to generation. It includes cultural and traditions. So traditionally, if I don't believe in epidural, I don't take epidural. So ethics. So we have the definition of ethics. It's principles of right and wrong, good and bad, governs our relationship with others. So ethics governs our relationship with others, good for wrong and bad. And then is used to identify solutions to problems arising from conflicts. We use ethics to identify problems that are arising from conflict. It's also based on personal beliefs and cultural values that guide a decision that we make. And as cultural diversity increases, we need to understand ethical principles as it also increases. The American Code of Ethics decision-making framework for solving a problem. So I'm coming to discuss their steps of them. American's Code of Ethics. American Nurses Association has a code of ethics for nurses. So you need to also know that. Nurse provides care with respect for human dignity and uniqueness of individuals without consideration of social or economical status, personal attributes, or nature of health problems. So you don't select the patient. You have to provide care. If you are black, you are black. If you are yellow, you are yellow. If you are green, you are a green person. I am your assigned nurse and I do everything I am supposed to do. There's no choice. Nurse safeguards the client's right to privacy. You have to respect. I spoke about the patient's right or the client's right, bill of rights. We did that already in another video. Look for that and watch. Nurse acts to safeguard client and public when health care and safety are at risk from incompetent, unethical, or illegal practice of an individual. The nurse assumes responsibility too and accountability for own individual actions and judgments. So you are responsible and you are accountable for your actions. That's why you are a professional. The nurse maintains competence in nursing. You have to be competent. That's why NCLEX is testing you. The nurse uses informed judgment, competence, and qualifications in accepting responsibility and delegating nursing activities to others. The nurse also participates in activities contributing to the nurse also participates in activities that contribute to development of the profession's body of knowledge. So we participate in activities that will help in developing knowledge. Participate in professions' effort to implement and improve standards of care. The nurse also participate in professions' effort to establish and maintain conditions of employment conducive to high quality nursing care. So these are all what the nurse should be doing. So we have the ethical principle for nursing. I'm going to be very quick on this aspect and I'm going to rush it up. So let's take notes. Ethical principles of nursing. We have autonomy. Ethical principles of nursing. Autonomy. This support of client independence to make decisions and take actions for themselves. So the autonomy you give to the client is to support their decisions and their ability to make decisions for themselves. Beneficence, the duty to help others by doing what is best for them. The duty to help others by doing what is best for them. Client advocacy for refusal of care. Autonomy overrides beneficence. So autonomy overrides beneficence. So if I want to do what you want or what will benefit you and you are not interested, that's autonomy. It overrides what I want to do for you. That will be of help. So non-maleficence, do no harm. Do no harm. Non-maleficence. Act with empathy towards patient and staff without resentment or malice. Violated by act performed in bad faith or with ill will, or when making false decisions, accusations about the patient or employee. So this one is non-maleficent. Do no harm. The principle of do no harm to anybody. You should have empathy with a person. Justice, use available resources fairly and reasonably. So this is justice. You have to use any resources that is available fairly and reasonably. Veracity, that's to communicate truthfully and accurately. Don't make false statement in the patient chat. If you didn't do the action, don't document you did it. Confidentiality, safeguard the client privacy. Fidelity, following through on what the nurse says will be done. Carefully attending to the details of the client care. Fidelity, following through on what the nurse says will be done. So you tell the patient, I'm coming back with your insulin. Don't go and go home. Bring it back. That's what you said. Fidelity. Ethical reasoning process. You have to recognize a moral issue. You analyze the facts and identify the dilemma, decisions that are possible with alternative decisions, and then you select specific action. You evaluate the effectiveness of the action. Behaviors for handling complaints. You use active listening without interrupting or arguing. Don't get defensive. If you're a nurse, you never get defensive. You ask person what is expected for solution to problem. You ask them, what do you want? What do you think will help? Because the patient is aggressive. What caused it? You have to identify that. You have to talk to the patient. Agree on specific steps that will be taken and determine a timeline. Don't just agree on the steps and say, okay, tomorrow. You forget it. Patient education, assessment. Now I'm talking about patient education. I'm running very quick on this one. Patient education is the job of the nurse. NCLEX want to know how much you can educate. So your assessment skills, you define education and is the process of learning. The types of information that need is a specific knowledge, and the type of learning should be cognitive, psychomotor, and affective. Those are the types of information, the specific knowledge, and the types of learning you need. Cognitive, psychomotor, and affective. Patient motivation. Patient may need help to see need for learning. Some patients don't know why they need to learn. The patient is being discharged home on a trach. It's going to be suction day and night, and the patient still don't see the need to learn. You have to explain to them. Important to remove barriers to learning. So if you know that there's a reason why the patient is not ready to learn, you try to remove the barriers that will stop that. Patients need health behavior desired. If the patient needs a healthy behavior, you have to help them get it. Current level of knowledge or understanding. So the patient that is not educated, the patient don't really have a background knowledge of what sepsis is. So you have to educate them. Skills level, patients' attitudes and beliefs, social, cultural, environmental factors influence their health behavior. Now you have to have their diagnosis. You have to know their diagnosis as well. You educate the patient on their diagnosis, and this one required a good skills. You need a mutual goal that will be set, and then the patient has to give you a feedback of critical decision they want to make. Factors that influence compliance with health regimen is the duration. If you're giving me a treatment that is a long-term duration, like let's say dialysis, that is a chronic one, that the patient is going to continue for the rest of their life. It's chronic, so it's going to affect their compliance level. So if the treatment is just to take the medication for 3 days or for 1 week, it is fine. If it's to take it for 2 months or for a year or forever, it becomes difficult to comply. Complexity, greater complexity causes greater non-compliance. I just said that. The side effect of the medication will also affect. So if you're educating patients on that, take note. Implementation, you have to, before you implement your plan activity to educate, you have to set priorities. You have to be realistic in your goals, what you want to get. You have to tell the patient, when you take this, this is what will happen. You have to consider involving the family and the significant others when you educate patients, because sometimes you educate the patient and they themselves forget. Sometimes significant others are those who help in the plan of care. They are those who participate more, and they are those who will help the patient to accomplish what they need to accomplish. You point out any success or benefit. Sometimes you say, okay, you did good on that, you took that medication and it worked right. Then you evaluate the patient. So is the patient able to verbalize their understanding of the plan that you have educated them? So anytime you tell a patient, you teach the patient something, you have to go back and evaluate. Now let's talk quickly about discharge planning and home care management. You assess with the first encounter. So discharge planning starts immediately after admission. So you get the family and other support systems that are identified. You start your discharge process the moment you admit the patient. Every day you assess the patient, you have the environmental factors that will be identified in the patient going home. You have the community agencies, you provide them with a list of helpful phone numbers that they can call for help. So if the patient is going home, you have to involve the community support systems, especially if they need care at home. Now, okay, so you have to get their diagnosis, and then you plan, you collaborate with an interdisciplinary team, which is usually the case management or home care agencies, and they will also make the appropriate referral if they need. Remember, all that is cost that is involved. So you have to get the patient the right monitoring. If the patient need a home health nurse, the home health aide to come and be staying at home, you have to state all those needs, and it starts with the nurse planning on them and collaborating. This comes to collaborative or interdisciplinary team for nursing staff. You become an advocate. That's the advocacy role. Is the patient health status relatively stable at home? That's what you consider when a patient is being discharged. And then, is the patient making the expected progress in terms of rehab? So sometimes they're discharging the patient to a nursing home. You want to follow up and make sure the patient get the appropriate care that will be needed in that particular nursing home, and that you may not be the one calling the nursing home, but you involve the case management, you involve the social worker, and they get that. Some patients don't even have a house to go to. They don't even have a place of abode. You have to work that out for them as well. Have the patient and family psychosocial needs being recognized and addressed. You have to recognize their psychosocial needs, and then you address them. So my next topic will still be on safe and effective care environment, and this time I'll move to infections and infection control. Infections and infection control will be our next topic. So watch out for that video as well. I do want you to watch these videos and make a note from it. I want you to understand. You can always repeat the video till you understand these things. Some of these things you don't necessarily need to read them. You just need to understand what it is, on the NCLEX, so that when you start getting questions on them, you are not messed up. Your mind will be well fixed and posed to answer those questions right. You have to crack NCLEX, man. You cannot waste any more time. You cannot fail again. Okay, so I'll see you later. I'll see you next time, and watch out for the next video on safety and effective care management, effective care environment, and this one will be on infections and infection control. Thank you for watching, and repeat the video till you understand. Bye bye.